So we will get started, everyone. Thank you for attending our June webinar, the summer webinar series. Just a little housekeeping details. You'll notice there's a chat feature and also a Q&A feature. We are hoping to have an interactive dialogue, but if you do have questions specific to the content, we'd ask that you do put it in the Q&A section so we can better keep track of the questions and make sure they're addressed. This webinar is being recorded, just for your information. And that's pretty much all of the housekeeping. There should be a raise your hand feature. So if you are asked to come off mute, or if you do have a question that would be better suited to be spoken verbally, just raise your hand and we will unmute you. I'm super excited though for this webinar and to have our speaker join us today. Kara Berg-Raunik, I hope I'm pronouncing her last name correctly. She is a SANE as well, so that's what's super exciting about it, and she has a wealth of experience. So with that, I will be turning it over to her to talk about herself and get started on content.
Cool. Thank you so much, Susie, and thanks to you all for having me. Okay, so this is a little weird because I normally like to, it's weird for everyone, even a year and a half in, because wouldn't in person be better? But also because I feel really strange that I can't see your faces. So like Susie said, please feel free to come off mute or get in the chat with me, and I'll ask you some questions that you can sort of throw in the chat. While I introduce myself, I would love it if you would introduce yourselves to me in the chat. So tell me, I was going to say where you're from, but honestly, I don't know anything about Wisconsin. So you can put that in for each other's benefit, but I will have no idea what that means. And other than that, you have really awesome sounding like city names. But if you would tell me kind of how long you've been practicing as a SANE, and also what your other background was in. So that'll kind of give me a sense of your exposure to women's health and to some of these infections and emergency contraception concepts, and just sort of know where we're at. So go ahead and throw that in the chat for me. That would be amazing. And again, my name is Kara Berg-Raunik. I am a women's health nurse practitioner with a doctorate in nursing. I have been a certified SANE nurse for over a decade now. My practice as a SANE started in Ohio, which is where my nursing career began. I was at the Cleveland Clinic at the clinic's forensic nursing service. We practiced full scope forensics. Most of our patients were sexual assault patients. We also, of course, saw lots of domestic violence, some elder abuse and neglect, some child abuse and neglect. I always say, like, I took care of a woman with a dog bite on Thanksgiving. So you know the breadth and depth of what we do. I since moved to Indiana, and I'm not practicing as a SANE here. I'm practicing just as a women's health NP. So it's been a minute since I've laid hands on a kit. So I always want to own that and be honest about it. But very much at the center of my practice, I've been really honored to partner with some of our forensic nursing teams more locally to do some follow-up for their patients. And also spent about a year and a half consulting for the Indiana Coalition to End Sexual Assault, helping to sort of rewrite and update the Indiana state guidelines for the medical forensic care of the adult and adolescent sexually assaulted patient. So very much try to still keep my hand in it. Again, my practice as an NP is really focused on family planning, women's and sexual health, sexual medicine, also some vulvar disease thrown in there that I'm really passionate about. But I say all that to like help lend the street cred to the discussion about STDs and emergency contraception and so on. So thank you so much for joining me today. I am going to just take a second and read through the introductions, because what's the point of asking you to do it if I don't read it? Okay, ER and ICU and some SANEs who have been doing this work for a long time, and some new SANEs. Amazing. Welcome to the work. And OB. Okay, cool. Thank you for that. I always say the ER nurses scare me, right? Like I joke, the sickest I want my patients chlamydia. So I think you all are amazing. Cool. So let's get started. Again, please feel free to throw something in the chat if something's not working for you, and we'll go from there. So we're going to start by talking a little bit about STD testing and prophylaxis for the SANE patient. And I'm going to hope that the slides advance. There we go. Okay. No conflicts of interest. I do want to just take a minute to talk about language. STDs obviously can occur in those identifying as any gender, right, with any genital configuration. But some of the stats and the language that I used are based on research, which is typically done in a gendered fashion. So I ask your forgiveness if there is a little bit of sort of cisnormative dialogue that goes on here, but hang with me. And give me that grace as we're working through. Also, of course, STD versus STI, you'll hear me use a little bit interchangeably. The CDC is still really using STD, and so that's the language that my organization rests on. Oh, I should mention, I work for an organization, a nonprofit called Healthcare Education and Training. And we are committed to basically improving sexual and reproductive health outcomes and adolescent health outcomes within kind of the 6 Great Lakes states. So Wisconsin is one of the states that we serve. We have an office both in Indianapolis and in Wisconsin. So one of the other reasons I'm really excited to be doing this for you all today. Okay, so STI, sexually transmitted infection, can be considered less stigmatizing. We know infection can lead to disease, but we know that STIs can often be asymptomatic. But again, in keeping with the CDC language, you'll probably mostly hear me say STD today, but please feel free to use whatever language fits you best and whatever your patients understand the best. Okay. Why does this matter? Why are we spending our time on this beautiful summer day talking about this? Hi, Lynn. Thanks for putting that in there. Okay, so we need to be amazing at understanding infections because our assessment skills as SANEs have to be impeccable, right? We need to know what's normal, what's not normal. We also need to do amazing counseling on discharge, right? What are our patients looking for? Signs and symptoms, follow-up recommendations. How are they going to keep any consensual partners protected, right, as they go home? And also, what about our medications? We also need to think about the sequelae that can come from infection, right? It's not as simple as someone not wanting to get an STD. We know that an untreated STD can progress and lead to pelvic inflammatory disease, contribute to infertility, chronic pelvic pain, increased risk of ectopic pregnancies, not to mention the public health implications of someone being out in the world with STDs and not knowing about it, right? And then most importantly, at the heart of everything that we talk about today is the patient. And it is so common, I'm sure that you all share this experience, for someone to come in and they may not even know what it is that forensic nursing is or what a SANE nurse can offer to them. They just say that phrase, I just want to know that I'm okay, right? We know that the fear around STD and also unintended pregnancy resulting from assault just adds to kind of the trauma of this already horrific experience. So that's why it matters. I'm probably preaching the choir since, again, you bothered to show up today, but we'll set the stage that way. So when we're thinking about STDs, we can sort of group them in our minds in a couple of different ways. We can think about them by causative organism, right? Is this caused by bacteria, virus, or parasite? We can think about how it's transmitted, right? Is it skin to skin or fluid transferred? We can class them by whether they are treatable or curable, right? And this is the part I normally really like to ask you all to participate. So we're going to do that. We're going to use the chat. I hope that people are cool with that. Let's see how this goes. Tell me, what are the bacterial STDs that you can think of? Someone throw some in the chat. What's a bacterial STD? Or you can unmute if you want to, I think. Gonorrhea, absolutely. What else? Chlamydia, yes. I appreciate the abbreviation because, man, spelling chlamydia is hard. Okay, hold on to the thought about BV. Thank you. Anything else? There's one that we're missing. Syphilis, exactly. I think sometimes people don't think about syphilis being bacterial, but it is. It's caused by a bacteria. That little spirochete is a bacteria. And then trick. So I also often like think in my brain about trick as being bacterial because it's treated like a bacterial infection. It's actually caused by a parasite, a protozoan, but that's perfect. So that's kind of where we're at. Gonorrhea, chlamydia, syphilis, and then asterisk trick. How about the viral STDs? What are we thinking about? Toss them in there. These ones can almost all be abbreviated, so you don't have to worry about spelling. Herpes, thank you. HPV, human papillomavirus, absolutely. HIV. Perfect. And then also we can think about hepatitis in there. We're going to talk about another less commonly known one called molluscum as well a little bit today. So out of this list, what is transmitted by skin to skin contact? Don't need penetration, don't need fluids, just skin to skin. I so appreciate throwing things in the chat. I know that that's not the most fun way to interact. Herpes. Thank you, Sarah and Rachel. You can also totally write like, I'm not really sure. I just know that I don't want to get them. Yes, HPV. HPV is skin to skin as well. Thank you. So the last one that is skin to skin, it can actually be syphilis. Okay, again, it's kind of the point of contact of that little spirochete where that makes contact. So that is also skin to skin, which leaves our fluid transferred as being gonorrhea, chlamydia, trick, hepatitis, and HIV. Yeah, Susie's lifting up that syphilis is on the rise in Milwaukee. Syphilis is on the rise all over the place, including congenital syphilis. I mean, this could be a whole nother talk. But it's really important for us to be thinking about that and keeping that on our radar. So which STDs do not have a cure? What can we treat but not make go away completely? Herpes, absolutely. So herpes can be really, really well managed, and we'll talk about that. And then HIV, absolutely. And we've got better and better treatments all the time, but it doesn't go away. Hepatitis is also one that's a little bit funny because it can resolve on its own, but also can progress to chronic Hep B. And then HPV is also a little bit of a sort of gray zone there. But herpes and HIV are kind of the two that I want people to be thinking about. So that's perfect. So I've sort of given this away, but what is the sexually associated infection that is not actually an STD? Yes, BV. So BV, bacterial vaginosis, is really not an infection per se. You'll notice it's a vaginosis, not vaginitis, right? This is an imbalance. What this occurs, BV occurs when there's an imbalance in the normal flora of the vagina. This can happen for all kinds of reasons, right? The vagina is an amazing home for bacteria, right? It is dark, it is warm, it is wet. All the things that make bacteria really, really happy, right? But normally we have like a good balance. And when something happens that throws that off, this kind of less good bacteria can take over. And it is very, very, very uncommon to find BV in folks who have never been sexually active. Not impossible, but very uncommon. So we do see it mostly among sexually active women, and it is often associated with either multiple partners or a new sex partner. which makes sense because there's just kind of more stuff going on in there that could be changing the normal balance. But it's important to sort of lift up because again, a partner wouldn't need treatment. Cool. Does anyone know what STDs are most commonly diagnosed among women who have been sexually assaulted? So it's the same ones that are most commonly diagnosed. Yes, gonorrhea, chlamydia, trich, and then also BV. These may or may not be from the assault itself, right? Who is more likely to get an infection from a sexual encounter? A person with a penis or a person with a vagina? And why? Person with a vagina. Absolutely. Why? Good environment. Because of tears. Yes, exactly. Vagina is made of mucous membrane, right? A penis, hopefully, is intact skin, right? So it's just a more vulnerable organ. So folks who are assigned female at birth are more likely to get an encounter from get an infection from a sexual encounter. Now let's think about risk of transmission. If we think about the highest risk sexual behavior down to kind of the lowest risk, rank that out for me. What's the highest risk for getting an infection from a sexual encounter? We're thinking about types of sex that people can have. Multiple partners, sure, increases risk. So, okay, so someone wrote male, male, and yes, there we go, anal. So anal sex is your highest risk of passing or contracting an STD, followed by vaginal, followed by oral, much lower risk, and then finally followed by digital penetration with almost no risk. And same thing as we think through kind of that mucous membrane of the vagina versus the anus that doesn't lubricate and doesn't have as much stretch as the vaginal tissue does. That's why, right? Potential for more of those micro tears and so on. Can anyone guess what is the most common STD myth that I hear from patients every day? It's your chance to throw something really fun in there. Oh, toilet seat. Absolutely. We hear that. Not the most common one. But yeah, you can't get STDs from a toilet seat. Really, or a hot tub or anything else fun like that. That you couldn't get an STD from your first time is what I'm betting first time in the chat means. Or from sharing towels. Yeah, very low risk of fomite transmission. I would say the most common myth that I hear is I would know it if I had an STD. I have no symptoms, so I know that I can't be infected, right? Or my partner has no symptoms, so I know that they must be safe, right? So we're going to talk far more about all the STDs and all the things, but they really can have no symptoms and still be present. So that's really important thing. Okay, sorry, I should have given a warning, although you're all nurses, so you probably aren't surprised. We've got some pictures coming. Okay, we're gonna sort of talk through the STDs. So chlamydia, I won't read all of this to you, but most common in our younger folks can be transmitted through vaginal, oral, and anal sex, as well as perinatally. Incubation, which means the time from exposure to symptoms, is about 7 to 21 days. It does replicate slowly, so it can take weeks for symptoms to develop, and it absolutely can be asymptomatic. So we've got a symptom list. You'll notice one of the things you'll see, I'm going to go back for the vaginal picture. Notice what this discharge looks like. And then as we look at some other STDs, notice how similar they look. On the penis, you'll notice a sort of clearish discharge. Discharge can be clear or cloudy, but you'll notice on a future slide for gonorrhea that it often is more purulent. I wouldn't say that I could tell you for sure this is chlamydia by appearance by any means, But if I see the more purulent discharge, I'm much more suspicious of gonorrhea. So vaginal or penile burning, or excuse me, discharge, pain or burning with urination or sex, some spotting between periods, and pelvic pain, but again, most importantly, often asymptomatic. Okay. Only 10% of men and 5 to 30% of women develop symptoms. So very common to be asymptomatic. Sorry if you hear my child in the background yelling. Moving on to gonorrhea. So again, most common in younger folks, same transmission, incubation period a little bit shorter, 1 to 14 days. And you'll notice again that discharge on the vulva and vaginal opening could be pretty similar, right, to that chlamydial discharge. Signs and symptoms can have kind of a funky discharge with a little bit of a variant in color, pain or burning, pelvic pain, testicular or scrotal pain is not uncommon. And again, spotting between menses. We are going to talk about the changing recommendations around treatment a lot. The thing to take home about gonorrhea is that resistance continues to emerge. The treatment guidance has changed over the decades significantly. It became resistant to fluoroquinolones and sulfas and penicillin and tetracycline in the 70s and 80s. So really now cephalosporins are our only effective class. So fixing the oral medication is no longer recommended as front line or first line. It still can be used in certain situations, like for expedited partner therapy, or if you don't have access to the injectable. But this is really important that we are treating this correctly and well. We know that the minimum inhibitory concentrations, right? If you guys remember that, the mix are increasing. We continue seeing the dosage that's recommended increase. I always sort of joke, and it's not a good joke, but like we're all going to die of gonorrhea someday. Like I just think it's important to watch. I don't actually think we'll die of gonorrhea, but it is a bug to watch the way that it's evolving. I think that's all to say about that for now. Next, we'll move on to trick. So again, look at this kind of purulent white discharge can look again very, very similar. Although you'll see on the next slide a little bit better. Discharge with trick is often yellow-green, and it often is sort of frothy or bubbly. So, sweetheart, I'm teaching right now. I love you. Sorry. You can come give me a hug really quickly. The joys of working from home, right? Okay, I love you.
Love you.
Bye. See ya. Thanks. Okay. Trick is really interesting. It is an STD that a lot of people have never heard of, right? Which is bizarre because it's actually really, really, really common. It is a little bit more common in older women than in younger. And we saw, gonorrhea, chlamydia, especially clusters in our younger folks. This is transmitted really through vaginal sex. It's very rare, if ever, that it would be through oral or anal sex. You'll notice the bottom picture there is actually what the protozoan looks like under the microscope. So if you ever have the opportunity to do a wet mount or a wet prep or look under the microscope at trick, it's very cool. The flagella make it move all over the place, and that's diagnostic, and it's very, very cool. Not so much to have, but to see. Let's look at the pictures on the next slide. Again, very common to be asymptomatic. Only 30% of folks develop symptoms. So a couple of neat things here that we can see. One, the appearance of the cervix there. Does anyone know what that is called? I'll wait a minute and see if anyone can come up with it. On the bottom there, you see the sort of more frothy, bubbly discharge that would make me very suspicious about trick. This infection also often comes with a fishy odor. That odor, yes, strawberry cervix, thank you. It's called strawberry cervix if you want to be really technical, culpitus macularis. And how cool is that, that you can now whip that language out. I'm also going to ask you to think about where else might we see a cervix that looks like this or has sort of this more strawberry-y patchy appearance other than in trick. So going back while you think about that, if there's any other patient populations we might think about that appearance of the cervix with. Again, this amine odor can be released especially after intercourse, but patients may complain about kind of a fishy odor with trick. So nothing in there yet. I'll wait like 4 more seconds in case anyone has any more thoughts. PID, only if it's trick related, but that's a great thought. I have seen this sometimes with genitourinary syndrome of menopause. You may see sort of some more patchiness to the cervix when we don't have good estrogen on board, and also with testosterone therapy, that you can see sort of some cervical differences there. Okay, syphilis, and we will get pictures. They're just coming a little bit later. So syphilis is increasing. It is most commonly found among men who have sex with men, but it is increasing kind of across the board at this point. Can be transmitted through vaginal, oral, and anal sex, as well as congenitally. Again, congenital syphilis is really quite concerning. So all pregnant folks should be tested at least once during their pregnancy. You'll notice sort of a potential for longer incubation period. So syphilis goes through multiple phases. Begins with primary syphilis, which is typically thought of as a painless sore or ulceration that can be called a chancre. One thing to keep in mind, it's not always painless. So I think sometimes like if something's uncomfortable, people think like, oh, it can't be syphilis, and I wouldn't go there. But it is sort of a way to think about differentiating between herpes, for example, which would be very painful typically. This is the place where the bacterium entered the body, right? One of the things that's interesting about that, it will heal on its own in 3 to 6 weeks with or without treatment, which doesn't mean that it's gone, right? It's not cured, just the sore heals. So it would still, without treatment, then continue on to secondary syphilis. One of the things that's interesting, because it's painless, is that it actually can happen without you noticing, because if it occurs where the bacterium entered the body, that could be inside the vagina, inside the mouth, inside the rectum, and you may not be aware. Second stage usually comes with a rash, commonly on palms and soles of feet. And then it can, of course, progress to much more serious systemic damage to organs, neurosyphilis that can look Parkinsonian, so on. Testing is a little complex. There's sort of a multi-series test to confirm, which may mean that testing for this is not really appropriate in the same setting, or at least would be complex. The CDC says blood test for syphilis, PRN, decision on individual basis in the same context. Here's a couple of pictures. Primary syphilis. Sorry, that was really fast. Let me slow down. Primary syphilis. Secondary syphilis. This rash is often called the great pretender because it can look like so many different things. It can itch, it cannot itch, but again, commonly palms and soles. Herpes. So many folks are unaware that they're infected, which, when we've just spent time talking about how it is typically quite painful, that can be confusing. But the lesion can be mistaken for other conditions. For example, I thought it was just a folliculitis, something like that, right? So let's talk about, we know 12% of 14 to 49-year-olds have HSV2, which is what typically causes genital herpes. However, we know that the overall prevalence, excuse me, of genital herpes is higher than that 12%. Can anyone come up with why that would be? If HSV2 is not present, how could we have genital herpes? Type 1, absolutely. Thanks, Rebecca. So HSV1 is what typically causes cold sores, right? HSV2 typically causes genital herpes, but because of the wonders of oral sex, they can switch, right? They won't switch, like they won't, inside your body, but you can auto-inoculate or again, through oral sex. If someone has cold sores present, someone could end up with a genital herpes outbreak, okay? Very common to be asymptomatic. That initial outbreak is typically the worst, can be accompanied by flu-like symptoms, so on. Some photos. You'll see kind of the, can appear as both blisters or sort of shallow ulcerations or erosions. So we've talked about this a bit. Initial outbreak can have fever, body aches, some lymphadenopathy. There also can be what's called a prodromal phase, meaning that just before the outbreak, sometimes people will be able to perceive some symptoms that tell them that it's coming, like people describe shooting pains into their legs a little bit or tingling. It's really important to know that while asymptomatic shedding can occur, so you can shed this virus even when you don't have a sore present, there's the most viral shedding going on during this prodromal phase and when sores are present. So I'll often remind patients, like if you are someone who gets this prodromal kind of symptoms, that is not the time to go say like, oh, I'm going to have a lot of sex right now because then we can't when I have an outbreak. Rather, to know that that would be an especially contagious time. The CDC does not recommend testing for the general population or for the SANE exam. That is because, so testing can be done by taking a swab of a lesion. And I would argue that if you do see a patient who has a sore that is suspicious for herpes, that's your window to do that testing. So it might be worth checking in with whoever's signing your orders to see whether or not that's something that they would like swabbed at that time, because that's kind of the opportunity to do it. But we don't do blood tests for this commonly, although blood tests do exist. And that's because, again, it's the same virus that causes cold sores. So what happens if you get a blood test back that says like, yes, you tested positive for herpes. And now I'm like, okay, for all we know, you got a big smooch from great Aunt Denise when you were 3 or whatever, and now you have this in your bloodstream. And so we get that result back and a patient says, oh my God, I have genital herpes. And we say, I really don't know. There is good treatment available. You can treat either episodically, just when there is an outbreak, or suppressively, meaning take medication every day to try and limit or eliminate the risk of having recurrent outbreaks. A benefit to suppressive is that it can reduce the risk of transmission. So we can't cure this completely. We can manage it really, really well. Again, a reminder that symptoms don't need to be present for it to be transmitted. How's everyone doing? Do we have questions? Should I take a pause, Susie? Is everyone okay? I hate not being able to see you.
So far, no questions have come up in the Q&A.
Okay, awesome. Cool. HPV, the human papillomavirus. This can present in multiple ways. They say that nearly all sexually active adults will be exposed to HPV at some point in their lifetimes. It's very, very common. There is a vaccine available. It can cause, again, several things. So some strains you would never know that you had. You would just be exposed, and it would kind of do its thing. And typically, immune competent folks will clear this on their own. It can also cause genital warts. Again, there's no great test for warts other than to see if what you are looking at is a wart, right? But someone's exposed, we can't like test them to see if they're going to get it. The one place that we can test for HPV is with a pap smear, right? Because HPV can cause changes to the cervical cells that can progress to cancer. And it also can contribute to oropharyngeal cancer, which is on the rise, likely linked to the increase in oral sex, anal cancer, penile cancer, vulval and vaginal cancer. Again, generally clears on its own in young, healthy, immune competent people. But one of the things that's complicated is it's unclear if it can be unclear if it's just sort of hanging out latent and might reactivate, or if it's truly cleared. So that's sort of a complication for folks. Incubation can be long. So for warts, it can be weeks to months. Cervical changes can be months to years, and cervical cancers could even be decades potentially. We talked about this, that there's no real test. So this is going to be not applicable for the SANE exam unless you're seeing the lesion. Okay. So this next one is a STD that many people have never heard of, called molluscum contagiosum, which really sounds like a Harry Potter spell. So molluscum can also be found not infrequently in pediatric populations. This can be a case of fomite transmission, right? Molluscum is a pox virus that's transmitted via skin-to-skin contact, but in kiddos, it's one like STD that can appear in kiddos without us getting really worried about abuse occurring or something like that. Not that you shouldn't still do your due diligence, right? But it's not uncommon for kiddos to get this from sharing towels. Sometimes we'll see like locker room outbreaks, kind of things like that. So often confused with warts when people see it, but there's a couple of kind of diagnostic characteristics about its appearance. And you'll notice sort of, especially on that top picture, it is, they are like dome-shaped papules with this little umbilicated center that often looks like it's got a little white core. And that is fairly diagnostic around molluscum and different appearing than HPV, than warts, okay? Again, we're probably not really gonna be dealing with this much in the SANE setting, but I do think that it's worthy of you knowing because you might see it. It will probably regress on its own within 6 to 12 months. So many people choose to say like, okay, who cares? And other people think like it's kind of icky and they don't like it. And so it can be treated similarly to warts. Okay, hepatitis. Can be transmitted by blood, semen, and vaginal secretions, can be asymptomatic, but can also have this nice list of symptoms. Chronic hepatitis B can lead to cirrhosis or carcinoma. In 1991, the hepatitis B vaccine became routine for children. Sometimes people don't know if they've received this vaccine already. So if you're talking to one of your SANE patients about this, know that repeating the vaccine is not harmful. If it turned out that they were vaccinated already and they thought they weren't, it's okay. But it wouldn't benefit them, right? So I think some programs are dabbling in this and some are not, just saying like, follow up on this, okay? So again, because of that routine vaccination, rates of new cases have declined by 80% since 1991, which is pretty amazing. Yeah, I'll leave that there. So next we're gonna move on to talking about HIV. And I understand that you had an amazing presentation on this last month that is recorded. So if you missed it, I'm sure that Susie can direct you to the presentation. So I will let that sort of stand and just go over a couple of things quickly. In the SANE context, this is really sort of important. We're thinking about, so with HIV, we're thinking about post-exposure prophylaxis, right? And whether or not someone should receive this. And we think about this at with a sort of higher level of critical thinking than we do when we talk about prophylaxing for things like gonorrhea, chlamydia, and trich in the same setting. Um, we know that NPEP must be started within 72 hours. The sooner the better. I remember when I first learned about this, I don't feel like that was emphasized, right? It was just sort of like, oh, you have 72 hours. Nope, like the sooner the better. Don't get sort of comfortable because you've got time in that window, but also know that if it's outside of that 72-hour window, you really can't begin it. So this algorithm is going to help you sort of work through whether or not you're going to think about starting NPEP, and also just really, really detailed counseling, right, with your patient and whether or not this is sort of a path they want to walk. NPEP is a 28-day course, talked about the 72 hours. You must test for HIV before initiating, because if someone were HIV positive prior to starting this medication, you could actually make it harder for them to find the right cocktail for them for HAART, for highly active antiretroviral therapy, for their long-term management of their HIV. So this, you really must test before initiating. I do have the asterisks there because if you are in a setting where that is not possible, like truly not possible, there are situations where you can go ahead and initiate the PEP and then get a test as quickly as possible afterwards, where you would stop it if results came back positive. But in general, you want to operate as if you must test prior to initiating. So we know that in consensual sex, the per act risk of HIV transmission from vaginal intercourse is 0.1% to 0.2%. For receptive anal intercourse, it's 0.5 to 3%. So again, there's lots and lots of factors that we're going to think about in this setting, including how you're going to provide and obtain that medication in those 72 hours and ongoing, right? If you're in a setting where you're able to provide a starter pack, that's amazing, or have some kind of a partnership with a pharmacy, because again, we have that tight time frame. But typically you're going to want follow-up with someone who specializes in HIV care. And so it may be that you're giving a starter pack and then they're getting the rest of it elsewhere. Programs are being so creative about figuring out how to do this for our sexual assault patients. It's really been quite amazing to see, but unfortunately it's still complicated, right? There's a cost, and hopefully, and I'll let Susie sort of jump in on this or throw it in the chat. In Wisconsin, I'm hoping these meds are covered somehow through one of your kind of crime victims funds. But again, that can be complex. You want to make sure that your patient is going to adhere to this 28-day course. And then again, whatever kind of follow-up is necessary. So there is a link between HIV and other STDs that's important to be aware of. Having an STD makes you 2 to 5 times more likely to acquire HIV if you are exposed. And that can be, if we think about why, and normally I'd love to make you come up with it. So if you want to throw something in the chat, go for it, but I'll kind of keep talking. A couple of reasons. Also, by the way, someone who is HIV positive with another STD as well is more likely to transmit the HIV. And there's a couple reasons behind that. And one is we've talked about, okay, Susie put in the chat about cost. It is that NPEP is covered under SAFE, but the problem is the cost of the meds far exceeds the SAFE maximum payout, and that makes sense. So this is always challenging. Again, many of the drug companies have programs, but this is work and hard, and worth the work, but challenging. So sorry, I was like squirrel. Going back to the link between HIV and other STDs, several STDs come with sort of increased risk of ulceration or general irritation, and that can create a portal of entry to the skin. Also, inflammation from things like gonorrhea, chlamydia, ulcerations, trich, increase the number of CD4 cells in genital secretions, which can then be targeted by the HIV. We also know that HIV is more likely to be shed in those increased secretions. So that's why there's that link. And then this phone number at the bottom there, that PEP line, is invaluable. Geniuses sit on the end of that line. So if you ever have questions about how to manage something, whether a patient is appropriate, they're amazing. So I'd throw that phone number in your phone or on a resource card. Next, we'll chat about BV. Again, not really an STD, but you'll see on the next slide, I'm going to peek at it first. I should have changed the order of these pictures. Sorry. There, you'll notice how similar this discharge can look to the gonorrhea and chlamydial discharge and to the trick discharge, right? So this is the most common vaginal condition that's seen in 15 to 44-year-olds. We've talked about this a little bit, that it's that imbalance of normal flora. One thing that's important to note, although we spent all this time saying it's not an STD, it can be passed between female sex partners. So if both partners have vaginas, you may want to offer a partner treatment or talk about that, right? Doesn't mean that it was acquired sexually, right? But it can be passed between partners when they both have vaginas. Okay, this is another one that comes with a fishy odor that can be worse after intercourse, so similar to that trick discharge odor. Again, this is another one that can be diagnosed by looking under the microscope at the wet mount, similar to trick. So I have treatment up here, which is metronidazole, 500 milligrams twice a day for 7 days. There's also a gel. This is a medication that does not play well with alcohol, like not even a sip, you will vomit everywhere. Okay, so that's really important counseling. Next, I've got some pictures of yeast. Again, yeast is not an STD, but is another sort of vulvovaginal condition that you may see. A couple of these pictures, you see that sort of in the bottom left, the sort of classic and top right, cottage cheesy kind of curdy discharge, which doesn't have to be present for yeast to be present. It can be more normal looking discharge, a more physiologic looking discharge, but this certainly is very suggestive. You'll also notice some of the vulvar manifestations. There can be some kind of fissuring of the skin, redness of the skin, and general irritation of the skin. Okay. So 75% of women or people with vaginas will have at least one yeast infection in their lifetime. The classic symptom is itching. Again, not generally sexually transmitted. CDC does not recommend partner treatment, but important for you to know about because you may see skin that looks like this in that top corner. And this is a reason that you want to be really thoughtful in your documentation of really describing what you see. You wouldn't want to talk about this as there being tearing secondary to the assault necessarily, right? You would just sort of talk about fissuring, redness, right? Things like that. Okay. So how are we on time? We're kind of okay. All right, to test or not to test, right? What is the issue with a test? What does a test tell us if we are seeing our patients within 96 to 120 hours of an assault? What does that test tell us? Someone throw this answer in the chat. What do we think? Yes, there is little forensic value in patients who have been previously sexually active, right? Now, there are situations where testing could have legal implications, right? If someone were not previously sexually active, then a baseline negative test followed by a positive test, especially if the suspect were positive, would be really important. Also, if any kind of threats or anything around transmission was an element of the crime or of the assault itself. But yes, it takes time for these infections to show up on a test, right? So, you know, we normally say we want about 2 to 3 weeks, right? When we think back to the incubation period, for a test to show positive. So if we're seeing our patients, you know, within those first 120 hours, it is probably from something before the assault. And that's really important for patients to understand because again, often they come in saying like, I just want to know that I'm okay. And we can't quite give them that reassurance in this way, right? Of course, there's public health considerations. Some of our patients were the only medical care that they're receiving, right? The only time that they're seeing a provider. And in that case, we'd certainly love to know if they have an STD, even from a previous encounter, because they probably need partner treatment and so on. There's some question around costs. And again, I don't know how the world works in Wisconsin exactly. I did see that the SAFE funding includes evaluation, testing, and prophylaxis for STD. But if it doesn't have forensic value, again, I don't know what the milieu is in Wisconsin, but there's a world in which someone's going to push back on that, right? And what does that look like? I would argue that our duty is to the health of the patient and not to consider, not to change what would be best medical practice based on thinking about court. But we also have to keep in mind that in spite of rape shield laws that are in place in all 50 states, rape shield laws, of course, that limit any evidentiary use of a previous sexual history, right, to undermine a survivor's credibility, right, that like stuff does come up, right, and so there can be concerns around that potentially. And then the CDC and the WHO have slightly different recommendations, okay, around testing versus not testing. The CDC says compliance with follow-up visits is poor among survivors of sexual assault. As a result, routine preventative therapy or prophylaxis after a sexual assault should be encouraged, okay? So typically, that is what's recommended, is prophylaxing at our point of care. I have heard people argue around antibiotic resistance and things like that, that is not the right way to go. But I would argue that this is a way to provide some emotional peace in this moment of real trauma, and that based on that, the benefits probably outweigh the risk. The WHO leans into the decision to offer prophylaxis should be made on more of a case-by-case basis. And they are less, they fall less into a camp of recommending routine prophylactic treatment. And yeah, Jill just mentioned that if you test too soon, you can get a false negative. Exactly. So if someone was assaulted within the last 48 hours and we test today, even if they were to end up having contracted something, we wouldn't know, right? So just prophylaxing takes care of it. I think we covered this pretty thoroughly, but you really, 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 really want to obtain an HIV test before we would prophylax. So that one's a little bit different than the other things that we're talking about. So the CDC encourages us to consider NATs for gonorrhea and chlamydia, a wet mount or point of care test for TRIC, and then sort of on an as needed basis for hepatitis, syphilis, and HIV. And as we talked about, I would argue that if there's a suspicious lesion present, that trying to culture that for herpes is an appropriate step for your patient, but again, falls outside of sort of the normal sexual assault care. Okay, so this is really complicated to talk about right in this specific moment because the guidelines are about to change and they've already rolled out a little bit of change to the practice guidance. If you look at the CDC guidelines today that are based off the 2015 STD guidelines, empiric treatment is as follows. They are recommending 250 milligrams IM of ceftriaxone, a gram of Zith, and 2 grams of metronidazole. You'll notice again that I've mentioned alcohol caution. And I think that's really worth mentioning because we know that a lot of our patients are coming to us from circumstances where alcohol was involved, which may mean that they are not appropriate to take metronidazole at this moment. They also may be planning on going home and self-medicating, right, following their trauma. And of course, that's not the coping mechanism that I would wish for them or encourage for them, but it's really common and is okay if that's their plan, right? Or something that they think is in their future. And so it's a really important, honest, open, non-judgmental conversation for you to have with them, because the last thing we want is to be sending them home with profuse vomiting. So that covers prophylaxis for gonorrhea, chlamydia, and TRIC, and typically is found in a pretty solid order set that's pretty standard. These medications are all safe in pregnancy. They all, of course, have a side effect of nausea. So commonly it's encouraged to consider antiemetic, right? On the other side of the screen, we've already talked a little bit about NPEP, and you've got much more information from last month's lecture. Some programs are looking at vaccine. Again, we talked a little bit about the Hep B vaccine, as well as considering the HPV vaccine. And those are multi-series, multi-shot series for vaccination. And so you would need to set up follow-up. Okay. This is the like little emblem in the middle of the, oh, you can't see my mouse. Can you see my mouse if I'm over there? Maybe, hopefully, of the app, which is the greatest thing ever because all of our brains don't work well at 3 a.m. So check out the app and that's a wonderful thing.
Hey,
Oh,
Kara.
yes. Ooh, you scared me so much. Hi.
Oh, sorry.
That's okay. What's up?
There's a question that
Yes.
popped through. I thought it was good to address now.
Yeah.
Anyway, first question is in regards to what about allergies to the treatment recommendation?
Yeah. So we will talk about that a little bit on the next this next slide that's coming. But yes, so doxycycline is the alternative to the Zithromax, right? Doxy, of course, not safe for pregnancy. And then yeah, so the ceftriaxone is an interesting one. It's a little complicated, right? Because there is potential for sort of cross reactivity for folks with penicillin allergy and cephalosporins. So the good news is that the sort of reactions for first generation cephalosporins was 2.5 to 10% of people with a history of a true penicillin allergy, but the ceftriaxone is a third generation and the risk is much, 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 much lower. So someone who's just like, oh yeah, I had a bit of a reaction to a penicillin. We're not really going to worry about this. We're going to worry about this with true severe IgE mediated reactions to penicillin. So someone who has had anaphylaxis or Stevens-Johnson syndrome, these people we're going to treat differently. There are a couple of alternatives, which it's Gent. I always have to look it up. And I don't have it clearly written in my notes here. Is Gent, I don't know what alongamycin means. Maybe it's just like a typo, but yes, gentamicin is still being utilized. This is also something you can always you might want to consult if you've got, I mean, certainly these aren't choices you're going to be making on your own, right? This is something you're going to be going to your doc about if you're going outside of your sort of normal protocol. But there is guidance from the CDC. It's another time to lean on your other specialists to try and figure out what the heck we do, because it is complicated. Okay. So that's a great question. I think one thing that is helpful to remember again is that it is less, the reactions are, hang on one second. Yes, Ruth. Okay, you have fun. Okay, good. Do you want to say bye to the people that I'm teaching? Can you wave? You can't see them because they're not on camera, but do you want to wave? Okay, cool. All right, have a good time. See ya.
See ya.
Sorry about that. Okay. And now I've totally lost my train of thought, obviously.
That's okay. There's another question on there anyway.
Great.
So
and BV, no, it won't cover BV. BV needs to be the week. So so just the 2-gram dose does not take care of BV. That is for trick. So BV would need a week. So if you have a patient where you think that is what's going on, you're going to talk about doing that differently. Thank you, Lynn, for putting that in there. Cool. Okay. So now we get to talk about literally like hot off the presses, December 2020 changes. So for active gonorrheal infection, remember when we talked about emerging resistance and how this is such a concern? They have now changed their guidance. It used to be 250 milligrams IM, which is what we saw in the previous slide, and they recommended dual therapy. So that Zith wasn't just to treat chlamydia, it was actually like really assertively treating, synergistically treating gonorrhea. Now we're no longer recommending dual therapy, and they've increased that dose of ceftriaxone. Also, by the way, this is now weight dependent. So it's a full gram if patients weigh more than 300 pounds. That's something else to consider, okay? The new guidance includes that if chlamydia has not also been excluded, then you're going to also do a week of 100 milligrams of doxy twice a day. Okay. This is obviously a lot less sort of straightforward than just taking a gram of Zith and calling it a day, right? Um, and when this sort of practice update came out, they explicitly did not include updates to sort of special circumstances like sexual assault prophylaxis. So we are sort of waiting on that guidance and in this sort of limbo space. What we know is that resistance to azithromycin is increasing. So it is incumbent upon us to be prudent and judicious in our use of antibiotics, right? So I do think that it is likely that we're going to see real encouragement coming, and the guidelines will be out. So if I'm wrong, ignore this completely, but that if it is at all possible to use the week of doxy, that is the better path to move down. Again, this gets into similar concerns, like frankly, kind of like with the HIV meds of like, do you have a mechanism to provide medication, right? Can you dispense? Do you have a pharmacy that you, like an in-house pharmacy? Because it's different than you just giving meds, in your environment that they're taking in front of you. So I do think this will be complicated. We may see that they continue to recommend azithromycin due to its ease of use. In this context, we'll just sort of have to wait and see. Different programs may be doing things differently for a little while. My understanding is that a lot of people have already gone ahead and made the change to the 500 milligram dose, even though that is not currently updated, right? But that is a change that many folks have already gone ahead and made. So again, check with your medical directors, do your reading and all the things, and we'll just sort of continue to see how it rolls. Bottom line is you're going to follow your hospital policy or your program policy. Okay, also a note about giving the ceftriaxone. It is an uncomfortable shot, so you're typically going to be mixing it with lidocaine. Okay, that is sort of the kind way to do that. All right. Any other questions on that? I know that's like clear as mud as we're in the middle of these change. Right, yeah, like totally. Are any concerns with compliance by the patient? Yeah, anytime that we're giving something that they need to do over a week instead of something that they're just gonna pop down in front of you, like it increases compliance concerns. So I'm curious if it may be something that we're case by case, seeing what's best and what's doable. If someone says, look, there's no way that I'm going to take a week of medicine, either because they're trying to keep it from people, or from people that they're living with and don't want people to know, or whatever the reason may be, it's certain. You're going to have to see what the guidance is. What I say doesn't matter. And Becky, to clarify, should you be doing the doxy, you want to check with your program. Some people may have changed already based on, a guess with this December update, and many have not yet, because again, they've been very clear that right now the guidance is still the 2015 guidelines until the new full update comes out. So that probably depends on sort of how sort of proactive and guessing your medical director is and your program is being, and we just don't know yet. So I'm betting that some have made the change and some haven't, and we'll just have to see.
Kara, did you see that in the chat, or did you just address that?
Yes, I think that's what I just said.
Okay, sorry.
Yeah, I think that's
I was answering a question on the Q&A, so.
Got it. Thank you. Awesome. Yeah, I think that's where we were. So follow-up recommended at 1 to 2 weeks. Again, remember that I talked about that I would always prefer that someone has at least 2 weeks after a sexual encounter that's concerning to trust testing. If they come in for follow-up, and this may be with your program, it may be that you're referring out. Of course, if testing was done, you'll review results. You're going to assess for signs and symptoms of infection. And I do think that something that's important to keep in mind is that the CDC doesn't just blanket recommend STD testing following a sexual assault if prophylaxis was given. And I always like to mention that because I've heard about situations where, a patient comes back from a follow-up exam and especially would tell like an advocate, yeah, we didn't do any testing, and the advocate is outraged. that care wasn't comprehensive. And so I think it's important to lift up that, like, if there are no symptoms, testing isn't necessarily encouraged, especially if prophylaxis was given. Certainly if symptoms are present, we're going to test. And I would also argue that the patient's mental health matters, obviously. And so if it would just give them peace of mind and reassurance to do that screening, I think that's totally acceptable. Okay. So we're going to monitor for any side effects and adherence to those prophylaxis meds, review any longer term follow-up. So ongoing testing, like getting HIV testing down the road, any follow-up vaccination doses. And then, of course, being really thoughtful about holistic, comprehensive care for these patients, right? Have they connected with advocacy? Have we looked at counseling, things like that, other referrals? So the CDC recommends for this exam that there is an experienced clinician, which many of you are, and some of you are not, and you will get there. I think just having sort of the compassionate, trauma-informed lens that you bring to your care by your background as a SANE already means you're ahead of the game on what you're supposed to be providing to patients and what patients deserve. That perpetual focus on minimizing re-traumatization. It's always one of my least favorite things to hear the SANE exam discussed as such a traumatic event, or that like the body is a crime scene model. Remembering that like we are nurses first, and that we are always going to be putting the health and welfare of our patients above. Well, we are forensically minded, right? And we serve our patients best by helping them if they choose to pursue legal action and all the things, right? And by getting the best comprehensive forensic experience that we can. We are nurses first, right? So I always give the example of like, if a patient was wearing her favorite pair of jeans at the time of the assault and she declines to give those up, that's within her right. We're going to talk about the reason that they want that collected for evidence, right? And what maybe the disadvantages to not turning them over as evidence. But that's their right, right? We know that it is a tiny fraction of our patients that will ever see the inside of a courtroom, and that the vast majority of our patients will experience healthcare sequelae secondary to the trauma and secondary to the assault. So that's sort of the mindset. Again, decision to test on a case-by-case basis, and encouraging prophylaxis as appropriate. We've got some references. And some more references. And any questions before we move on to emergency contraception? I'm going to start setting up the next PowerPoint. Well,
oh, we got a question that's going to come through on verbally.
Great.
Verbally, audibly. Hold on a minute here. I'm going to go find it. Was Sarah Kolb. I'm finding you, Sarah. There you go.
Can you hear me?
Yes, thank you.
Okay. So I have a question. I always have difficulty around patients who come in with like you had mentioned earlier, with trick is very transmittable between like vaginal and vaginal assaults. Sometimes I have difficulty. How are we? Let's say we have like a PETA oral assault. I mean, should we be treating everything prophylactically, or only treat the STDs that can be transmitted that way?
Yeah, so say that one more time. You said what, so if it was only an oral assault?
If it was an oral assault, or, I've had vagina to vagina assaults, I've had all different types of contact, and it always gets a little confusing whether we should give the entire, prophylactic regimen, or just limit which medications we give to treat what could be transmitted.
Yeah, I mean, I think that's a really thoughtful question. I would certainly be doing gonorrhea and chlamydia almost all the time. I think if it were just oral, there's certainly room to consider skipping the metronidazole. And it may be something that you want to, consult. Again, in my program, we weren't routinely doing metronidazole, we weren't routinely prophylaxing for trick, and looking back, I'm like not sure why. We probably should have been doing it a lot more than we were. So I think that going case by case on that is intelligent. I also think that like doing one dose of metronidazole is not going to cause significant harm. So if you know your program's decision is like, look, we don't think real critically here, we just do it, that's also a reasonable approach. And that if there is more sort of case by case clinical judgment there, you just want to make sure that you know, are you the one that should be making that decision? Do you need to confirm that with the prescriber? Like what else does that look like? Does that help a little? Is that a totally non-committal answer for you?
No, yes, that's very helpful.
Okay, cool. Thank you. Cool. Anything else before we emergency contraception? How are we on time? Oh, we only have 20 minutes. Do we really only have 20 minutes? Oh my gosh. Okay, we're gonna blow through emergency contraception then. Cool. Okay. Let me figure out share screen. Man, I hate how fast it goes. Okay, let's see. And cool. Is everyone seeing what I want people seeing? Yes?
Yep, looking good.
Okay, EC, still no conflicts of interest. Okay, pregnancy after assault, the body does not shut that whole thing down. Remember when we had a politician that said that? That was awesome. Okay, so this is a major fear for patients and often also for their loved ones. So we talked about like, what are they coming in for? Often it's just to make sure that I'm okay, right? And that often has to do with this fear around pregnancy. Risk of pregnancy after an assault is 2 to 5%, which is the same as the risk from any other single sexual encounter. Okay, so normally I would ask you to help me generate these questions, but mostly I'm just gonna blow through it for time's sake. So type of assault affects the likelihood of conception, right? Just like the STD question. What activities can you get pregnant from? Sounds facetious, but I want you to not forget to think about emergency contraception in the context of an anal assault as well, okay? Because of drainage, okay? Certainly less likely, but not out of the question. And given the magnitude of the concern, I think it's worth considering emergency contraception in that context. So likelihood of conception, of course, is impacted by presence or absence of ejaculation, presence or absence of a condom. Are they contracepting normally? And if so, are they using their contraception correctly, right? You want to be thoughtful about how you ask your history questions. It's not at all uncommon for me to have a patient where when they're asked, you know, what do you use for birth control? And they say, Depo, and I say, great, when was your last shot? And the answer is 6 months ago. Well, then they're not using Depo for birth control right now, right? Or same like, yeah, I use the pill. Well, when did you take it last? Oh, well, I ran out a week ago and I haven't refilled my prescription. Well, then they're not really using contraception, right? So you want to be thoughtful about that. Where are they in their menstrual cycle? This is really important. And often people don't really know, right? But ovulation occurs typically, and we're talking about the typical menstrual cycle for the like every woman archetype, which is not everyone, right? But ovulation would occur on day 14. Remember, we count menstrual periods from day 1 of bleeding, right? So when we're counting this, it's not from the last day that you bled, it's from the first day. We care about the first day of LMP. So ovulation based on that is day 14. We know that sperm can live in the body for up to 5 days, and the egg can live for about 24 hours. So based on all of that, we are most concerned about the likelihood of conception on day 9 to 15-ish, okay? Doesn't mean we're not gonna worry at all through the rest of the cycle, because again, everyone is different, and most people aren't that tuned into their cycles, but day 9 to 15 is our highest risk. Okay. I would be remiss if we didn't talk briefly about reproductive coercion, which is just to say that So 30% of those who are raped by an intimate partner also report reproductive coercion by that partner. Reproductive coercion means someone who has interfered with their contraception or condoms, or applied significant pressure on pregnancy or pregnancy outcome. We know that that patients who have been raped by a current or former intimate partner are more likely to report pregnancy secondary to rape compared to acquaintances or strangers. Okay, it's just a couple of things to keep in mind. So this should be discussed with all patients of reproductive capability. And this is an important place to stop and talk for a minute, because there's a lot of folks who have reproductive capability that we sometimes don't think about. Or where patients themselves don't count themselves in that realm, and you get to sort of redirect that. So an example of a special population like that would be someone who's perimenopausal, right? A lot of older folks may think that they don't have the ability to become pregnant anymore, but remember that the definition of menopause is 12 full months without a cycle, which means if you go 10 months without bleeding and then bleed, you start that 12 months over. Okay, so someone who's in that kind of a mode may not consider themselves to be at risk of pregnancy, but could be. Also, folks with a history of infertility. I've had patients come in and say like, oh, I have PCOS, so I'm not worried about it. No. People with PCOS are it may be harder to become pregnant, but it doesn't mean that you can't, right? Things like that. Also, breastfeeding, unless they're exclusively breastfeeding, then there still can be a concern. Even with exclusive breastfeeding, it's not the most efficacious method of birth control, so I'd still consider talking about emergency contraception. We also have to consider our trans male patients, right? So if they have not had a hysterectomy, they have the potential to become pregnant, even if they're on testosterone, even if they're not menstruating, okay? Another one that comes up sometimes is people who say, I know that I can't take birth control. People have medical contraindications to birth control, right? Luckily, the emergency contraception really doesn't have significant contraindications. Most birth control related contraindications are more related to the estrogen component. So even someone who says, I've been told I'm not supposed to be on birth control, probably is safe for emergency contraception. Important note, this can be a complex topic for people. ACOG defines pregnancy as beginning at implantation, not at fertilization, but humans defined pregnancy personally. So it's a really important place for you to take some time to really look at your own values and make sure that you're using caution not to influence your patients one way or the other. We may not understand or agree with their choices in this area, but we just need to do a little self-work to be ready to manage these conversations in a really supportive and appropriate way. If a provider declines to provide emergency contraception for personal, spiritual, or moral reasons, there must be a mechanism in place to provide information on how the patient can receive emergency contraception somewhere else in a timely fashion. So my program, there was one ER physician on the adult side who would not sign for emergency contraception. So our workaround was that when he was the one working that day, our pediatric side physician would step in that setting. So whatever your circumstance. And I was looking, it does look like Wisconsin is one of 18 states that does require ERs to provide information about emergency contraception to sexual assault victims, and one of only 14 states required by law to dispense EC upon request to sexual assault patients. So that actually may not be so much of a thing for you, but regardless, I've included a little bit on access. So some places where you can find sort of ordering options, okay? Plan B became over the counter in 2013 without age restriction, regardless of gender. So that's something else to keep in mind. That's the levonorgestrel-based emergency contraceptive pill, okay? So to provide emergency contraception, you're going to want to do a pregnancy test because we don't need to provide EC to someone who's pregnant. We're going to assess time frame, has to be provided within 120 hours. We're going to offer emergency contraception, and we're going to go through a really awesome informed consent process where we talk about their options, the mechanism of action, any side effects, and any required follow-up. There are 3 types of emergency contraception available. One, and the most commonly seen in this context, I think, is the levonorgestrel-based pill. There's a ton of brand names, but you may hear it referred to as Plan B or Next Choice. But that is a progestin-only pill. Then ulipristal acetate, the brand name is Ella there, but ulipristal acetate. And then IUDs can also be used as emergency contraception. There's also some regimens of combined hormonal contraceptive pills, but they're less effective and have more side effects. So I'm not really going to talk about those. They're not really recommended. So the levonorgestrel-based pill, again, can be taken up to 120 hours, but efficacy decreases significantly at 72%. 72%, goodness, excuse me, 72 hours. Prevents about 50% of expected pregnancies. It works by delaying ovulation. Remember, it's a progestin, which is synthetic progesterone, right? So there's no adverse effect on the endometrium after fertilization. If anything, it would enhance the progesterone effect. So it would not interfere with implantation. There are no known ill effects on a fetus or maintenance of a pregnancy if already pregnant. But again, its primary mechanism is the delay of ovulation. Side effects are rare, but you can see them listed there. It is effective until the beginning of the LH surge. Okay. We talked about it's available over the counter to anyone. One sort of big barrier here is that it is less effective for folks with a BMI over over 25, and ineffective for folks with a BMI over 30, which is, a lot of our patients. Considered safe for breastfeeding, no significant contraindications, none, and also no interaction with other hormonal birth control. So if someone is on another method, this is fine to take without pause. And I apologize again for going so quickly. Ulipristal acetate is available by prescription only. It is a selective progesterone receptor modulator. So it can work either as an agonist or antagonist, depending on when it's taken in the cycle. Based on that, it does maintain its efficacy through the full 120 hours. So if you have someone between 72 hours and 120 hours, this may be the best bet. This is not as commonly available in my experience in SANE programs. And unfortunately, while we could get a prescription written and sent out, it's not always stocked in pharmacies. So if this is something that you're thinking about for your patients, you want to make sure that there's a pharmacy near where you're doing the exam that has it stocked, because of course we are still under that time frame. So it's not an effective medication, typically for the pharmacist to order and get in several days later, right? Again, mechanism of action is delaying ovulation, rare side effects. What else? It has a long half-life. So we think that it can delay ovulation through the lifespan of the sperm, that may be part of why it's more effective. Okay. There's a little bit of conflicting evidence around whether or not it may alter the endometrium. One study showed that it can, and 2 studies showed that it does not. So that's sort of the question. But generally accepted that, again, its mechanism of action is delaying ovulation, not interfering with post-fertilization events. It may also lose efficacy at higher BMIs, but higher than the levonorgestrel based. It is not recommended for breastfeeding. Because it is secreted into breast milk. So the recommendation is typically to, I hate the phrase, but to pump and dump for 24 hours. There can be a concern for interaction with other hormonal birth control because of how it binds to the progesterone receptors. So other contraceptives basically can compete with the ulipristal acetate and reduce its efficacy. So if someone is like, I just take my pills pretty inconsistently, but I'm definitely planning on continuing my pills, there may be a little concern around that. If they have been off birth control and are wanting to start, they can start 5 days after taking the ulipristal acetate without a concern. But that's sort of an extra complication of this medication. It's possible that some medications may decrease the efficacy, so you'd want to think about that as well. So if you have a patient who is really overweight or has another reason that some of this may not, that these may not be good options, one thing you can consider is an IUD. And IUDs can be used off-label as emergency contraception. They are highly effective, by far the most effective method. The problem is that this often is not really an appropriate option or an available option in a SANE setting. First of all, this is typically not something that can be done by just an RN, like that's terrible, but by an RN. And also it's not like a terrible procedure, but it is crampy, and it is a little bit of a longer, would require a longer speculum exam and things like that. And so there's some concern just around what the with the like milieu of the trauma that's ongoing, how that would look. It does need to be placed within 5 days. So it would be wonderful if you had a partner clinic or provider available that you could make a warm handoff to get someone in quickly if they need an IUD for emergency contraception. Does work by creating a sterile inflammatory response that is toxic to both egg and sperm, and also produces that inflammatory response in the endometrium. So again, unlikely to be an option in the SANE setting, but could be a follow-up option. So again, this can feel more complicated to people because based on a standard medical definition of pregnancy, it is not an abortive agent, but people have different personal values and beliefs, and so this may or may not be comfortable for someone. Recent update, again, hot off the presses. Historically, we've only used the copper IUD for emergency contraception. But now there was just a non-inferiority study that showed that several of the levonorgestrel-based IUDs can also be used for emergency contraception, which is wonderful because one of the advantages here is that if someone wants ongoing high quality effective contraception, they can have this placed for emergency contraception, then continue use, right? So now there could be a good choice, right? So they have different side effects. They have different lengths, right? The copper IUD can stay in place for up to 12 years. The levonorgestrel base can stay in place for up to 7. Bleeding profile is different, so on and so forth. So this is really awesome that this is again just brand new. Oh, sorry, wow, practice change. Sorry to whiplash you on the slides there. I think that's about it on that. If someone is doing the oral emergency contraception, if they vomit within 3 hours, they should retake a dose and consider an antiemetic for them as well. If they've not had a menses within there's some sources say within the expected time frame and others say within 3 to 4 weeks, they should do a pregnancy test. Their cycle may be different. It may be lighter, heavier, just hard to say. Another point of counseling that's really, really important is to remember that emergency contraception is for previous acts of intercourse. It does not protect against future sex acts. So if they have a consensual partner at home taking EC with you, does not mean that they can have unprotected sex, later that day, right? In fact, based on how it delays ovulation, it's possible that it could even make them more likely to get pregnant, right? So, just that's an important little snippet of counseling. References. That was the world's fastest emergency contraception. Holy wow. Any questions? Anything at all? We're close on time, but I haven't kept you over yet, so that's good. Please feel free to come off and unmute or throw something in the Q&A.
While we're waiting for questions, I am going to pop in the chat a link to our post webinar evaluation. So that's there. It'll also be sent to you in an email, probably, at the close of today through Zoom. So you'll have it that way. And if you have a question, you can raise your hand. I can have you off mute.
And shameless plug, I'm excited to get to come back and talk to you again next month. We're going to talk a little bit about trauma-informed pelvic care, which I'm really, really looking forward to. So hopefully I'll see you and some of your colleagues then as well. And you've got my contact information. I'm always happy to chat, answer any questions on this stuff, on vicarious trauma, other trauma-informed topics, anything else that I can help you with. It's always a pleasure. Thank you.
Awesome. Well, if there's no questions, then we'll let you guys go. And yes, I'm super excited for next month. So that was like a preview plug. Next month, she returns to talk about trauma-informed pelvic care, which I'm super excited about because we all know about trauma-informed care, but taking it to the level of when the patient's like literally on the table, I think is going to be fantastic. So save the date, or information about that will be coming out probably at the close of this month for July. So you'll have that to register for that coming up in a week or two. Thank you all.
Thanks so much. Take care, guys.